Good evening, everyone, and welcome to my IVFenses. Welcome to European Fertility Society. I'm glad that you are all here, and I'm sure it's going to be another interesting session tonight. As you can see, our special guest, Dr. Halyna Strelko, is back with us. I'm very, very excited that you are able to connect tonight with us, and it's always great to have you here as our presenter, that's for sure. Hi, Dr. Halyna, how are you, and how have you been?
Hello, good evening. Thank you for your kind invitation. It's true that it was some time that was difficult to do the webinars from different point of view because we was out of home. We was during these events evacuated. But now we restore our work and now we can restore also our webinars. So I'm really happy to participate and to do this presentation tonight. Hope it will be helpful because I try to show all answers to most frequent questions of my patients of this topic.
Brilliant. Thank you so much that you were able to, join us. If you had a chance to already participate in one of our webinars with Dr. Strelko, I'm sure you know that it's going to be an interesting session, no doubt. And of course, tonight is definitely interesting and also difficult topic as well. It's about egg donor conception, and Dr. Halyna will walk us through all aspects of egg donation. And remember that after her presentation, there will be time for your questions. So all you need to do is just put those in the chat section. And after the presentation, Dr. Strelko, I am sure will be happy to help you out with any questions that you have. And just to remind everyone, if you don't know already, Dr. Strelko is a co-founder, leading reproductive specialist at IVMED Fertility Center located in Kiev, Ukraine. And we are happy that you are able to connect, as I've mentioned. And I'm really looking forward to see the presentation, to listen to what you have prepared. And I'm sure it's going to be interesting. Remember, this is being recorded, and so you will have a chance to watch this. It will be available tomorrow on our website, of course. And I guess we can go ahead with our presentation. So thank you so much, everyone. And let's go ahead, okay?
Yeah. Thank you.
Here's the presentation. Thank you so much, Dr. Halyna. Let's go.
Yeah, thank you. Thank you for your kind presentation, yeah, of me. And now we will start our presentation about egg donation. Why this topic is so important? The name of this topic is Donor Egg Conception Dilemma. What should you know before you start? And why it is really necessary, because egg donation is quite different to standard IVF treatment. And there are some specific questions to understand before you start your egg donation program. And very often patients does not know which points they should clarify before to start, and what exactly they should looking for when they are choosing the clinic. So let's try to answer all these questions. So the main questions from patients before egg donation program mostly presented in this slide. First of all, who are oocyte donors? This is the more important question. So I will show you how we are selecting our donors, what kind of exams we are doing, how we found our donors. Probably most of clinics doing more or less by the same method, but necessary, of course, to ask and to see how it is organized, because it is very important. Also very important which kind of examination was done to egg donor, possible risk of egg donation to both parts, also how to prepare yourself to the pregnancy, and very important question is protocols of preparation, because depending on protocols, maybe different kind of complications even. and also success rate necessary to discuss and to see which conditions increase, improve success rate, and which conditions may decrease. So, what about legal issue? In Ukraine, we have a document, order of the Ministry of Health of Ukraine, and it is described who can be egg donor. So it should be woman less than 36 years old. A very important point that in Ukraine, a potential egg donor should have as minimum one healthy child. So it means that egg donor should have proven fertility. It is not for all country like that. Also important that we should control the negative habits like smoking, like alcohol, like drugs, and we are doing that. Also, there is a request to have satisfactory somatic health. It means not have health problem, serious disease. Also, should be a lot of exams. I will show you. So we are doing different blood tests. We are doing also, as I have mentioned, drug tests. Important to see if there is no some specific contraindications like cysts, like endometriosis, like fibroma. Also, we are doing mandatory psychological screening of donor. For some country, it is asked to do some specific tests. For example, for US, we are doing what we call MMPI test, metric test, which can give us more exact information about psychological status and about risk of some psychiatric disease. And if we found such risk, okay, we exclude donor or, for example, testing more deeply. Also, very important point is screening for inherited disease. Also, normally we are doing 6 more spread genetic mutations in our population, but also for some country or some patients, we can do more wide examination, like 250 mutations or 340 mutations. So it depends on population and request. And in case we are doing such screening, it is also very important to know that mostly all people have some mutations. Only depend how much mutations we are searching. The main problem to see if your partner will have the same mutations and in this case will have the risk of some disease. So if you are thinking about such investigation, necessary to understand that both parts should be tested, otherwise it is useless. As I have mentioned about psychological testing, for egg donors, for some of them, the fact of egg donation may present some psychological issue and they can support it difficultly. And we have in our clinic 2 psychologists who support them and help them if there is some problem. And also, it is important to see the psychological profile of donor, because some patients would like to have a donor with optimistic character, some of them with more, how to say, introvert character, some of them more like scientific points in character. So it is important to have objective status because a lot of these things are hereditary. This is the list of obligatory tests which we are doing for our egg donors. You can see the infections like HIV, like hepatitis, like syphilis. Also some infections like mycoplasma, ureaplasma, herpes, cytomegalovirus. Also very important to see the anti-Mullerian hormone, because this hormone show the ovarian reserve, and we mostly does not accept candidate to egg donation with IMH less than 3. It means that average number of eggs which we expected to receive should be as minimum 20, but in average we have even more. Also, we are doing a lot of genetic tests like cystic fibrosis, like Fragile X, like spinal muscular atrophy, like hereditary deafness, phenylketonuria. But I repeat that the panel of genetic mutations may be more wide, and it is depend on request and on population, because for some population we can find the specific mutation. So necessary to understand for what population we are screening our egg donor. So if we can see the process of screening, we can see that only 20% of all leads, I mean contacts by internet, pass to primary interview. After primary interview, around 30% only scheduled for the first visit. And after that, only approximately 1/2 leave and continue the examination. So around 3, maybe 5% of all leads only became donors in our clinic. It means that the selection is quite strict, and it is the safety for patients. So if you will ask in the clinic where you are thinking to do the egg donation and asking to explain the process of screening, you will understand how deeply clinic do that, and how strict select donors. It is really important. So if we can see the statistic about age of donors, because this is the second more often question when we are talking about selection of egg donor. For example, 2020, we have done 268 egg collection, and total number of egg obtained was 8,700. And average egg number for egg retrieval was around 30, as I have mentioned, because we select mostly girls with high IMH level. And from all this amount, we try to see the quality of eggs according to the age, because quite often patients asking, oh, I prefer to have egg donor less than 25 or less than 30 or something like that. But is it really important? And we can see that number of follicles is a little bit slightly more if we have very young age, less than 25 years old, but still quite a lot. Oocyte number is also slightly more in young age. But if we can see the number of mature eggs, we can see the difference is much less. Yeah, we have around 24 in 25 years old, and around 19 if donor has more than 31 years old. And if we can see the percentage of Q1, it means the best quality eggs, we can see that the even more Q1 eggs we have in group between 26 and 30 years old. So, and also number of eggs which we can use from each egg collection. Also, you can see that the most of these eggs present in group between 26 and 30 years old. So, but finally, the difference is mostly zero if we will speaking about statistically significant difference. In young age group, young in reproductive medicine mean less than 35 years old. So in this group of patients, in reality, there is no statistically difference in quality and quantity of eggs. And also necessary to understand that even egg donors with proven fertility, so with healthy, normal children, does not exclude the possibility to receive eggs with not excellent quality, and sometimes we really receive such eggs. It is around maybe 8, maybe 10% of all donors, but we can have, unfortunately. Quality of eggs is mostly personal characteristic of egg donor. What does it mean? It means that if, for example, you have chosen a donor, and if this donor was in egg donation program before, and you can ask how many eggs was received last time, what was the quality, what was the fertilization percent, what was the blastulation percent, and also if pregnancy arrived, and if you receive yes to all of these questions, it means that probably you will have quite a high probability that you will have good quality eggs and good result. And also need to know that not all eggs may have excellent quality and may be used successfully. So approximately 60-70% of all mature eggs in average in egg donor program has really excellent quality. Also, question about donors' social status. Okay, probably it is not influence a lot on success rate, but anyway, we can say that most of our donors has high education or secondary specialized education, and most of them are working, and egg donation, it is rather like altruistic gest and not something like profession for them. What about results of infections examination? Because it is very important to exclude, because this is the safety of our patients and laboratory as well. So we found time to time some infections, some serious infections like hepatitis, HIV, syphilis, not very often, it is less than 1%, but in this case, of course, don't exclude from the program. In case on detection of mycouroplasma or something of types, some infections of cervicids or other, we can do treatment, then we can control, and if results are negative, we can continue. Some problems like uterine myoma, like ovarian cysts, like some precancer disease. Okay, also sometime we can found, but in this case also we don't continue. Genetic disorders, we found, if we test only 6 genetic disease, we found around 3% of our donors. But if we are doing what we call carrier screening, mostly all donors has some mutations, but most of these mutations has not clinical significance. Here you can see what kind of mutations we found in our egg donors. So abnormal karyotype around 1.3%, some hereditary deafness 3%, cystic fibrosis 3-4%. In Ukraine, in our population, these mutations may be found more often than in other populations, for example. Fragile X 1.3%. So the serious disease not very often, we found not very often, but still necessary to exclude them, because if we have such mutations, it may be very harmful for baby health. Okay, what about general outcome, because also when we are talking with patients that, okay, we have a lot of eggs, but necessary to understand that not eggs will be fertilized. Not fertilized eggs will reach blastocyst stage, and not all blastocysts will be good quality and without genetic abnormalities. For example, average number of oocytes usable per cycle is around 17. And average fertilization 15. Blastocysts 11, yeah, not half, but around 60%. And when we are doing the genetic test on these blastocysts, around 65% are normal. So we start with a lot of eggs, but we arrive to even not half of good quality and euploid blastocysts, which can give pregnancy. So necessary to understand that one egg is not enough in most of cases. Necessary to take some amount to receive as minimum 2-3 blastocysts for the transfer. So, euploidy rate in donor egg cycle. Why we have no, how to say, 100% of genetically normal eggs, and which can, what can influence on euploidy? So, in average, euploidy rate reach around 65% in most of clinic, but in some clinic it may be less, and in some clinic may be more, and it may depends also on laboratory conditions, also some cultural mediums, some peculiarity of cultivations, and also gamete and embryo manipulations method, for example, air impurity in laboratory may also influence the aneuploidy rate. So it is important to know if laboratory conditions correspond to standard, because it is influence on results so much. Also, further age may influence aneuploidy rate, because more age, more late reproductive age has partner, has father, more DNA fragmentation we can see of spermatozoid, and also less blastocyst we will have, and more aneuploidy rate we will found in these blastocysts. So after 50 years old, even a healthy partner may have more DNA fragmentation. In average, it is twice more when we compare with less than 39 years old. Also, we has less blastocysts, so we should take much more eggs and more quality to reach the same result. And also we will see that the aneuploidy rate in this blastocyst will be higher. So worse sperm we has, more eggs we should take. It is simply rule, but also necessary to take attention to that. So we have our own results of aneuploidy, but it is more or less the correspond to standard results published in scientific literature. We have quite low level of mosaicism or embryo without diagnostic. And if we will try to calculate how many eggs we should take to receive as minimum 3 euploid blastocysts, to have as minimum 1 or 2 transfers. So if we know all these parameters of own laboratory, we can calculate that we should take around 8-10 good quality eggs. Of course, it may be different, but in general, we have such results with 8-10 good quality eggs. In some case, we can have more blastocysts, of course, but in general, we have as minimum 3 good quality blastocysts with this amount. Also, very important thing that safety of egg donor should be provided by the clinic because, of course, donor help us, donor help patients. And for patients, it is important to know that in case on some problem with health with donor, clinic will take care of this donor, and according to Ukrainian law, during 30 days after the retrieval, we have obligation to treat all conditions related to egg collection, to stimulation, and we are doing that, and it is important to know. So, possible causes of age-related fertility decline. Some of them related, unfortunately, on egg quality, but in case of egg donation, we avoid that because we have eggs of egg donors less than 35 years old, but some factors still stay, and it is mostly general health problem like diabetes, like hypertension, like heart disease. Also, some problem of uterus like endometriosis, like myoma, like some polyps, some infections inside of uterus like chronic endometritis. Also, some disease like coagulation problem. All that may increase the probability of implantation and increase the risk of premature birth. And before to start, necessary to see all these conditions. About aneuploidy, we have mentioned that mostly this depends on age. As we have mentioned that in young reproductive group, we will have more or less low level of genetic abnormality in eggs. But when we and also it is quite not very easy to answer to this question. Is it really necessary to do genetic test on embryos which was produced with donors' eggs? So we can see that from one side, the percentage of genetic abnormality in eggs of young girls is not very high. From another hand, some percent of these blastocysts may have genetic abnormality, and also very difficult question when we have a situation named mosaicism. When we have genetic selection of embryos, of course, it may improve the probability of pregnancy. If we select embryos only with results of pre-implantation genetic diagnostic, the probability of pregnancy rate is really high. But if we add another method of selection, like, for example, time lapse, it is the possibility to do the photo every 5 minutes of developing embryo, and then to artificial intelligence will calculate some parameters of embryo and will help to select the best of them with more reproductive potential. So if we use this and this time-lapse method, we can increase much more the probability of implantation. So from this point of view, probably PGD may be helpful because it is short the time to pregnancy. If we have situation when our laboratory give the result of mosaicism, a lot of question about that, and there was a lot of webinars about that. But what you should know that it is depends on how to say, by luck or by unluck, you can have more or less mosaicism, if we can say like that, because mosaicism, it is the situation where not all cells in trophectoderma has the equal genetic. And if your embryologist put your pipette here, by luck he will have like 5 cells, 3 good and 2 bad, and you will have 40% of mosaicism. But if by luck embryologist will take biopsy here, you will receive a result that your embryo is good, and it will be finally false positive result. And if here, for example, it will be abnormal, yeah, and it will be false negative result. So when you have not a lot of embryos, not a lot of blastocysts, try to discuss, is it really necessary to do genetic test, because it may decrease the number of embryos available for the transfer. For example, all these embryos has chance to implant and give healthy baby. But, for example, in this case, this embryo probably will not participate in transfer, and finally will not have chance to give a pregnancy. So this is very important to discuss as minimum, and to know that results of genetic diagnostic, it is not always 100% exact. There is some points which can be ambiguous. And when you have the result of your genetic diagnostic, the algorithm of selection of embryo for the transfer, it is like that. You start with normal, and then you go down. You can choose first low-level mosaicism with 1 abnormal chromosome, then low level with 2 chromosomes, and so on. So when we receive abnormal genetic result, it does not mean that impossible to transfer. It means that much less chance and maybe some problem after, and necessary to do much more diagnostic if pregnancy arrive. So this is about genetic testing. So also important point that several type of protocols which can we use during the preparation of endometrium for embryo transfer, they may influence the result and may give some conditions, some complications. Generally, there are 4 type of protocol: replacement hormonal therapy, natural cycle with triggering of ovulation, and low dose stimulation. If we see all possible types, it is described here in this table. So hormonal replacement therapy may be with what we call antagonist. It means that we switch off ovary and then give medication which imitate your natural cycle, or we don't use such medications, for example, in case of menopause. Also, it may be true natural cycle with luteal phase support or without. It may be modified natural cycle, and it may be mild stimulation. What is interesting that when we, here there is a picture of all these protocols, and what is interesting, when we compare what we call natural cycle and artificial cycle, we can see that all parameters are better in natural cycle. Biochemical pregnancy mean positive test, clinical pregnancy mean we can see in ultrasound implantation rate, ongoing pregnancy rate, live birth rate. Okay, difference is not very high, like 5-10%, but still we have this difference, and it is important to know that protocol of endometrium preparation may influence success rate. Also, artificial cycle may give more spontaneous abortion. Also, difference is not very high, but still may be like that. Another point which we can have with artificial cycle, it is the probability of some obstetric complications. Egg donation per se and artificial cycle may increase the probability of preeclampsia, because in artificial cycle there is no corpus luteum, and corpus luteum produce not only progesterone but a lot of other things, some vasoactive substances. And we can see that statistic in egg donation is from 13 till 18% the preeclampsia, but when we have multiple pregnancy, when we have twins, it is even more, it is 28%, and it is really 1/3 of all pregnancies. It is big statistics. So if you have replacement hormonal therapy, as minimum what you can do to have single pregnancy, not to transfer two embryos. Multiple study report on increased risk of preeclampsia in women conceiving by IVF also, but it is only around 5-6%. But for egg donation, it is unfortunately much more, because probably some immune issue, also because on this protocol of artificial of hormonal replacement therapy. During egg donation also may be some complications related to late reproductive age, like diabetes, like heart disease, and mostly we can see them after 40 years old, and especially after 45 years old. The arterial hypertension before 50 years old is around 26%, 28%, but after is around 60%. That's why probably in most of countries there is some limit of age for IVF treatment and for egg donation program. Gestational diabetes is around 20% in egg donation programs. Placenta previa 2 times higher. Also maybe more high probability of thrombosis, heart attack, stroke, and so on. Before the initiation of the egg donation program, it is important to find out the protocol of egg donor selection and screening to understand what exactly, which kind of genetic mutation was excluded. Also thinking about the same screening of your partner. The average blastulation and euploidy rate in IVF clinic is important to know, to understand how many eggs probably you will need for successful treatment, because as minimum will be good to have 3-4 euploid blastocysts. Careful check of own health, including genetic screening and general health screening, will be very helpful, because may decrease the probability of obstetric complications. In case on pre-existing diabetes, thrombosis, hypertension, and so on, is very important to check up and stabilize before to start. And in some case, obstetric risk unfortunately can be very, very high. If, for example, before the treatment, woman has diabetes, like metabolic syndrome, high blood pressure, thrombosis, so during the pregnancy it will be really catastrophe. The protocol of endometrium preparation may cause some complications as well, so also will be good to discuss the protocol of preparation before you start. So thank you very much for your kind attention. I am ready to your questions.
Thank you so much indeed, Halyna, that you were able to present this particular topic, and thank you for walking us through all aspects about egg donor and selection of the egg donor. And it is important. And of course, there are some questions right here, as you can see. So remember that if you have anything that you would like to ask, This is your time. I know that this is always your favorite time. So go ahead, type the questions in the chat. And now let's go ahead with the first question that we've got right here. And
Mhm.
it's from Christina. It's a bit of a longer one. So let's
Yeah.
have a look. Good evening, Dr. Halyna. Nice to see you again. We might need to consider egg donation at some point early next year. We were thinking in Ukraine because I understand that there is no non-anonymous egg donation, which means we can see pictures of the donors. Do you do gender selection? Can I ask what is the package, how many eggs, and are there any guaranteed blastocysts? Are you able to mention about the price of the package? Also, will it be possible to travel to Ukraine given the current political situation? Thank you so much for your question.
Okay, thank you very much for the question. So try to answer all points. So current political situation, okay, not so easy. We are working. We are doing a lot of egg donation program for Ukrainian patients. We have not so much foreign patients now. It is understandable because. Okay, in Kiev it is quite safe, but the problem that now it is a little bit difficult to come because no direct fly, but otherwise with train possible to come. So I hope it will finish one day. So probably next year it will be more easy. What about anonymous? So it is, how to say, little bit ambiguous because in our documents, official documents, written that egg donation is anonymous. But so me as doctor, I cannot show you the photo. But if you address in agency who helped to found egg donor, agency can show. So we resolve this problem like that. That agency can show you a photo of donor. For Ukrainian patients, we use children photo of egg donor. So like that. Also, we have enquete with general characteristics. Before this military situation, we tried to start the program of face phenotype matching, but okay, unfortunately not have enough time to finish that. Probably next year we will restart. About gender selection, in Ukraine there is no restriction, so it is not prohibit, so it is permit. About package, probably we will write you all information in details about price, packages, and you will receive by mail. So travel, okay, we discussed that travel now is possible, only it is a little bit difficult. We have patients who come for one day, we're preparing them by distance, they come for transfer and the same day or next day go. So
Okay.
like it is possible.
Okay. Thank you so much, Christina, for your question. As Dr. Strelko has mentioned, to give you some more details about prices, packages, of course, I'm sure it will be possible to email you all those details. And I hope that was helpful for you. Thank you so much indeed. Well, Christina has one more question here. So are we able to make all the choices, including age? Are the donors mostly Ukrainians?
Yeah, donors 99% Ukrainians. We have some period when we has Chinese patients and we has donors from Kazakhstan, but not a lot. And now we have no. So 100% of our donors are Ukrainians.
Okay. And what about age? Are you able to select?
Yeah, we give information about age. I mean, okay, if you have 3-4 enquetes and you prefer to choose enquete with enquete of donor more young, no problem. You can. There is a choice.
Right. Thank you
But
for the
it is not
clarification.
influence, as I have mentioned, does not influence the result.
That makes perfect sense. And just to remind me, how old can be the donor? Like the oldest donors, let's say, more or less.
Mostly no more than 32, 33 years old.
Exactly.
But in most of case, these girls are donors who has proven quality of eggs. That's why they still continue, and we
Mhm.
still invite them. So it is a little bit like positive selection.
Okay, of course. Thank you indeed for the clarification to this one as well. And
Mhm.
Christina, I would like to thank you for your help with the questions here. Okay, we have another question. How about are donor eggs shared between recipients?
Yeah, it may be because, for example, especially for Ukrainian patients, it's quite expensive. And okay, we propose to share donor with less price, and yeah, it's we can do that, and we say to people that okay, in this case, your donor was shared. We have different package like 6-8 oocytes, like 12 oocytes, 18 oocytes. So depends on choice, but. In most of case, 8 or maybe 10 oocytes is enough. But if we have very poor semen condition, low count or very high DNA fragmentation or previous attempts with very low blastocyst formation, in this case, better to take a donor with proven high blastulation rate and with more oocytes, because oocytes can repair sometime this DNA damage of sperm and improve finally DNA quality. And in this case, we have chance to have good embryo.
Yeah. All right. Thank you so much for explaining this one as well. And now let's have a look at the question. Sorry, here. Apologies. It's from Lenka right here. Good evening. Is it possible to test a compatibility of the egg donor with male partner?
Thank you for your question. Yeah, it's possible, but what do you mean compatibility? If we are speaking about this carrier screening test, it means that yeah, we can test donor for these 200 or 300 mutation. Then we can test your partner and then see if there is some mutations which are the same. And in this case, there is a risk of some disease of child. Yeah. So from this point of view, of course, we can do that. From other point, okay, probably I don't know. What do you mean?
Yeah, Lenka, if you can just simply clarify what you I mean, that we'll be able to help you out a little bit more, okay? Thanks. Okay, let's give it a second. I will be able to come back, of course, to this one. Okay, let's have a look. Next question is right here. Dear Dr. Strelko, hello, and I hope you are doing very well. How do you recommend couples cope psychologically after double donation? If the donors are anonymous, how do we come to terms with having a child that does not look like us?
Thank you. Yeah, it's a good question. We try to help to select phenotypically more or less similar. Of course, it is difficult because difficult to find two persons who are very similar, but as minimum some main things we try to select as couple has, for example, if couple has blonde hair, blue eyes, and so on, both donors should have the same characteristics, for example. So from this point of view, we try to help to select the best donor. Um, there is some programs, as I have mentioned, named Phenomatch, which can permit to found more physically similar, but unfortunately we have no chance with this military condition to install these programs. Probably when it will be more quiet, we will restart this work.
That's again understandable, yes. And of course, we did actually a couple of webinars on Phenomatch and how it works. So if you wish, you can go ahead, check it out. And yeah, hopefully you will be able to use it pretty much soon, hopefully next year, as you've mentioned as well. Of course. Thank you so much for your question. Believe that was helpful. And let's have a look. Okay, there's another question from Alex. Do the number of years egg sperm are kept frozen influence the possibilities of success? What about if many years passed? For instance, 10 years cryopreservation can guarantee same success as if cryopreservation was on 5 years ago.
Very good question. Thank
Indeed.
you. About sperm, we have even experience to working with the sperm frozen 40 years ago, and it was successful. The embryo quality was so, but still we had pregnancy. The main problem that after 20, 30, 40 years, cultural medium methods of thawing and all technology change for sure. So difficult to find the same medium who will be, how to say, acceptable, available for those method of freezing. So for sperm, in most of case doesn't matter because sperm cells are more robust for freezing. Yeah, they has less damage and support much easier this procedure. So for sperm, for sure, doesn't matter if it is 10 years. For eggs, if it was frozen by modern method 5 years ago by vitrification with modern solutions, probably also not a problem. But if eggs was frozen with slow freezing 10 or 15 years ago, it may be a problem, not because on 10 years, but because on different technology. So probably like that.
Yeah, thank you so much. Indeed, interesting question. And thank you for clarification to this one. Okay, thank you. And there are two questions from the very same patient. Patient, if you can have a look. Could you please describe the procedure after oocyte selection? Are they frozen? And let me show you the next one. Then oocytes are unfrozen to be fertilized. Then embryos that are not transferred are frozen again. Is that correct?
Yeah. Thank you very much. Yeah, we can work in with frozen eggs, but we can work in also with fresh eggs, the both. With frozen eggs, it is more easy because we can start the preparation of endometrium. One day when endometrium is ready, we thawing eggs, fertilize, and doing the fresh transfer, for example. So like that, it is more quick. But also we can thaw in, fertilize, cultivating, then freeze blastocyst stage, and then waiting when patient will be ready and thaw in the day of embryo transfer. So the both way are okay. A couple of years ago, like maybe 7, maybe 10, in most of case we has done synchronization of cycles because freezing program was not developing so well. And for that, we are using mostly fresh eggs. Okay, it take much more efforts because necessary to start contraceptive pills before patients and donor, and sometimes menstruation start earlier and eggs growing not so quickly. So it may give more problems synchronization, but also it is possible.
All right, and if I may ask, so right now, nowadays, you are doing more fresh cycles or frozen?
Mostly frozen.
Okay,
Mostly
thank you. Just
Maybe
wanted to.
50-50, because before we has done like maybe 90% frozen and 10% fresh, and now it is maybe 60% frozen and 40 fresh, something like
Yeah, as you've mentioned, frozen is much easier to synchronize, etc. with every
yeah. From
planning.
organization point of view, it is more easy.
Exactly. All right. Thank you so much for those questions. I believe that was again helpful. Right now, I do not see any questions. However, remember that if there's anything else you would like to ask, you can still do it. If not, you can just simply get in touch with Dr. Strelko and her team at IVMED, and I am more than sure they will be able to help you out with any questions you might have. If not, we will be finishing for tonight. But thank you so much, everyone, for your questions, for joining us tonight. And I believe it was useful for you. Dr. Strelko, we are happy that you are back. And before we finish, anything else you would like to add?
Thank you very much. I really appreciate this opportunity and hope one day all will be as before. And we
Exactly.
are really
We
waiting
wait
for
for that. Yeah, we
yeah,
all are waiting for that. And of course, I just wanted to add that Dr. Strelko will be back. There are some upcoming events, of course, in September, but she will also have a webinar in French, right? Very, very soon.
yeah.
So if there's anyone here that speaks French, understands French, you can sign up. It's still going to happen next week in July. So go ahead
In
and
August, 8th of
in
August.
August. Sorry. Yeah.
Yeah,
Okay. Sorry about that, but in such case, stay tuned. There are more events, and Dr. Strelko, as I've mentioned, will be back with some English webinars as well. I'm already looking forward to this. So thanks, everyone. We will have now a short summer break, so there will be no webinars in August. However, we will be back in September. So I just want to say thanks, everyone, for joining us over and over again as well. I hope that is all helpful for you. And simply, we wish you all the best, whether you are just starting your IVF treatment or you are in the middle or ending. Best of luck to everyone. We will be back. So stay positive. Dr. Strelko, thank you so much again. It's been great to have you back. And I'll be looking forward to our next webinar pretty much soon. Stay safe and take care, everyone. Have a lovely evening as well. Thank you so much.
Thank you. Have a good night.
Thank
Bye
you. Take
bye.
care. Bye.
Bye.